Okay, so my name is Sarah Liskowich, and I work at the as a hospice physician on an accountable care unit at the Pasqua Hospital in Regina. And for my CQIck project, I looked at improving communication between the inpatient pharmacy team. So we know getting patients from the community into the hospital and back home is a dynamic and multifaceted process where the healthcare systems, hospitals, providers, patients, and their families all share responsibility. Patients' transitions from one setting to another is a very vulnerable time, and it's when safety lapses can result in negative clinical outcomes and adverse events such as diversion of controlled substances in the community. There's 7 key elements essential for safe and seamless transitions, including medication management, transition planning, patient family engagement and education, communication and transferring information, follow-up care, healthcare provider engagement, and shared accountability across organizations. Currently, outpatient pharmacies are not routinely notified when patients are admitted to hospital, which I identified as a misuse of controlled substances can occur. So my aim statement was that by December of 2023, all patients admitted to Unit 4A at Pasco Hospital will have their outpatient pharmacy notified of their admission. By developing and implementing an outpatient pharmacy notification tool on admission to an accountable care unit ward, we endeavored to incorporate several of the key elements of safe transitions and care and explore whether in fewer medication errors and the minimization of inappropriate dispensing of controlled substances in the community through an earlier targeted communication with the outpatient team. Major themes that led to medication errors and opportunities for diversion of prescription controlled transitions of care include poor communication between facilities, lack of recognition of the problem for providers and patients, inconsistent processes for medication reconciliation and outpatient notification, as well as a lack of standardized expectations for providers. And you can see I'm older than Kayla because I've got my written instead of nicely typed there on the picture. After many iterations, here's my most recent diagram ideas, but in the interest of a 3-minute presentation, I'm going to highlight 2 of the primary drivers that were awareness and communication. Our patient family advisor input highlighted that patients are unaware that there is communication between the hospital and regular outpatient pharmacy when they're little, and many physicians and pharmacists admitted that they didn't consider the possibility of controlled substances being diverted and filled in the community while patients were admitted to hospital. So the hospital and outpatient pharmacies use separate information systems to track patients dispensed and they're accessible to each other in the 2 different settings. So we needed an appropriate means of communication between the 2 settings when we were considering what our intervention. Developing a process to notify the outpatient pharmacies of a patient's admission to hospital required consideration of and inclusion of all of the 7 Joint Commission key elements of transitions of care. This emphasized that even a small intervention or change idea required engaging multiple people and parts of a complex medical system to be implemented effectively. So upon admission to a Pasqua Hospital Accountable Care Unit medicine ward, the inpatient pharmacist performs medication reconciliation and the outpatient pharmacy is confirmed with the patient by the inpatient pharmacist at our daily bedside rounds. This was raising awareness for the patient is not routinely done, but is being implemented to improve safety and therefore provide better care to the inpatient. Then completed the outpatient pharmacy notification fax form and advised the outpatient pharmacy that the patient was admitted to hospital. This fax form also includes information to the pharmacists on how they can see when their patients are admitted to hospital and seeks their input to see if they feel this is relevant information and if there's anything more important that know while the patient hospital. On discharge, the discharge medication reconciliation form signaled that the outpatient pharmacist that the patient has been discharged. Our fax notification form to outpatient pharmacies was piloted over a 4-week period. An audit process was performed to ensure that it was consistent. Of the 7 patients during that 4-week period that we initially piloted, only fax forms were able to be completed, and of those, 46 included all of the quality control criteria that we identified as important. This audit identified ways to increase the percentage of forms that could be faxed through small process changes on the inpatient pharmacist day sheet and prioritizing this process on Fridays and Mondays, since there's no unit coverage of pharmacists on the weekends, increasing the opportunity to miss new admissions after discharge. It also showcased the importance of accurate data collection of patients admitted to the unit by unit clerks, reinforcing the need for every team member to accurately perform their job duties in order to test the intervention and improve the process. After another couple PDSA cycles to formalize consistently, we've attained approval from the SHA Research Ethics Board to contact patients and outpatient pharmacists to explore the impact of this added communication intervention. A summary of the findings will be collated with the purpose of running further cycles on the notification tool to improve this and its utility. We'd like to get to a place where all patients admitted to hospital have their outpatient pharmacy notified of the admission as early as possible in the stay to reduce the risk of medication errors and diversion of controlled substances in the community. The Accountable Care Unit provides a standardized care delivered by an interdisciplinary team, which is a key component to implement a consistent process. But opportunities were lost for patients who did not make it onto an Accountable Care Unit ward prior to discharge, supporting the expansion of this care model across the hospital setting to improve patient care and care provider effectiveness and satisfaction. By partnering across transitions of care to determine best modalities of communication and effective interventions can reduce medication errors and inappropriate prescription drug use. Thank my coach, Ron Taylor, and my inpatient and outpatient pharmacy colleagues, Nelson Tauris, Ken Bristol, Matt Mans, and my patient, Paula Kirk, and the research analyst, Michelle, for all their help on this project. And thanks to QIck for giving me the tools to move it forward.